Introduction. Welcome to today's lecture on thyroid hormone replacement therapy. In this comprehensive script, we will delve into various topics related to thyroid anatomy, function, the etiologies of hypothyroidism, diagnostic evaluation, and the management of thyroid hormone replacement therapy for different patient populations. We will also discuss the titration of levothyroxine dose, monitoring strategies, adverse effects and complications, combination therapy approaches, transitioning between formulations of levothyroxine, and the significance of patient education and counseling. Let us begin our exploration of these critical areas in the field of endocrinology. Thyroid hormone replacement therapy is a crucial aspect of managing patients with hypothyroidism. Hypothyroidism is an endocrine disorder characterized by deficient production or action of thyroid hormones. It can manifest through various etiologies, including primary thyroid gland dysfunction, autoimmune thyroiditis, surgical removal of the thyroid gland, or congenital thyroid hormone abnormalities. The primary goal of thyroid hormone replacement therapy is to restore thyroid hormone levels to the normal range, thereby alleviating symptoms and optimizing overall well-being. The therapy mainly utilizes synthetic thyroid hormone, levothyroxine. Levothyroxine is the preferred treatment due to its long half-life, stability, and bioavailability. Before delving deeper into thyroid hormone replacement therapy, let us briefly review the anatomy and function of the thyroid gland. The thyroid gland is a butterfly-shaped endocrine organ located in the lower anterior neck, below the laryngeal prominence. It consists of two lobes connected by a narrow isthmus. The thyroid gland is primarily responsible for the synthesis, storage, and release of thyroid hormones, which are thyroxine, T4, and triiodothyronine, T3. These hormones play a vital role in regulating various metabolic processes throughout the body, such as basal metabolic rate, growth, and development. The synthesis of thyroid hormones involves the uptake of iodine from the bloodstream by thyroid follicular cells. Within the follicles, iodine is incorporated into the amino acid tyrosine to form T3 and T4. T4 is the major hormone secreted by the thyroid gland, but it is mainly converted to the more biologically active T3 in peripheral tissues. Hypothyroidism can arise from several different etiologies. The most common cause is chronic autoimmune thyroiditis, also known as Hashimoto's thyroiditis. This condition is characterized by the presence of circulating thyroid autoantibodies, which attack and gradually destroy the thyroid gland, leading to decreased hormone production. Other potential causes of hypothyroidism include post-surgical hypothyroidism following thyroidectomy, congenital hypothyroidism due to thyroid dysgenesis or dyshormonogenesis, and iodine deficiency. Additionally, certain medications, such as lithium and amiodarone, can induce hypothyroidism through various mechanisms. Regardless of the etiology, patients with hypothyroidism experience a deficiency in thyroid hormones, resulting in a range of symptoms, including fatigue, weight gain, cold intolerance, constipation, dry skin, and cognitive impairment. Accurate diagnosis is crucial for proper management of hypothyroidism. The diagnostic evaluation begins with a thorough clinical assessment, including a detailed medical history and physical examination. However, clinical features alone are insufficient to confirm the diagnosis. Laboratory testing is necessary to measure thyroid function parameters. The primary laboratory test for assessing thyroid function is the serum thyroid stimulating hormone, TSH, level. Elevated levels of TSH indicate decreased thyroid hormone production, reflecting primary hypothyroidism. In such cases, additional tests, including free thyroxine, FT4, and total triiodothyronine, T3, provide further insight into the severity and etiology of hypothyroidism. In certain situations, such as during pregnancy or when monitoring patients on thyroid hormone replacement therapy, thyroglobulin and thyroid peroxidase antibodies may be measured. Imaging studies, such as thyroid ultrasound or scintigraphy, can be useful in evaluating structural abnormalities or identifying potential underlying causes. Levothyroxine, the synthetic form of thyroid hormone, is the mainstay of thyroid hormone replacement therapy. Understanding its pharmacokinetics is crucial for achieving therapeutic efficacy and avoiding adverse effects. Levothyroxine is a prodrug that requires conversion to T3, the biologically active form, to exert its effects. Following oral administration, levothyroxine is absorbed predominantly in the upper small intestine. Food, especially high-fiber meals, can impair its absorption. Once absorbed, levothyroxine undergoes hepatic metabolism, mainly via deiodination and conjugation, before being excreted in the bile and urine. Individual variability in levothyroxine absorption and metabolism can contribute to differences in drug response among patients. Factors such as age, sex, concurrent medications, and the presence of gastrointestinal disorders can influence its pharmacokinetics. The management of thyroid hormone replacement therapy requires special attention in certain patient populations. Pregnant women with hypothyroidism, for instance, should receive adequate thyroid hormone replacement to ensure optimal maternal and fetal outcomes. The optimal levothyroxine dose during pregnancy may require adjustments due to changes in hormone metabolism and increased thyroid hormone requirements. Pediatric patients with congenital hypothyroidism should also receive early and appropriate treatment to prevent adverse effects on growth and development. Levothyroxine dosage in children is typically weight-based, and regular monitoring is crucial for maintaining hormone levels within the target range. Elderly individuals often require lower levothyroxine doses due to age-related changes in thyroid hormone metabolism and increased susceptibility to adverse effects. Close monitoring and adjustments in dosage are essential to optimize treatment in this population. Achieving optimal thyroid hormone levels involves careful titration of levothyroxine dosage. The initial dose is generally low, especially in individuals with cardiovascular disease or a history of ischemic heart disease, to avoid exacerbation of symptoms such as angina or arrhythmias. The recommended starting dose is usually 1.6 micrograms/kg/day, with subsequent dose adjustments made based on clinical response and laboratory results. The goal is to reach a euthyroid state, generally defined as a TSH level within the target range, 0.4 to 4.0 μ/L. Dose adjustments are usually made in increments of 12.5 to 25 micrograms every 4 to 6 weeks until stable thyroid hormone levels are achieved. Close monitoring of clinical symptoms and laboratory results is crucial during the dose titration period. Excessive levothyroxine dosing can lead to thyrotoxicosis, while suboptimal dosing may result in persistent hypothyroidism. Regular monitoring of thyroid hormone levels is essential to ensure optimal therapy outcomes and prevent complications. The primary laboratory parameter used for monitoring is TSH. In most cases, TSH levels should be maintained within the target range for the specific patient population. Follow-up intervals depend on individual patient characteristics and treatment stability. Initially, closer monitoring, such as every 4 to 6 weeks, is required during the dose titration phase. Once stable hormone levels are achieved, follow-up intervals can be extended to every 6 to 12 months, with adjustments made as necessary. Additional laboratory tests, including FT4 and T3, are sometimes used in specific situations, such as when there are clinical concerns about the adequacy of peripheral tissue thyroid hormone levels or when assessing adherence and potential malabsorption issues. Thyroid hormone replacement therapy, while generally well tolerated, can be associated with adverse effects and complications. The most common adverse effects are symptoms of excessive thyroid hormone replacement, commonly known as thyrotoxicosis. These symptoms include palpitations, anxiety, heat intolerance, weight loss, and tremors. Other potential adverse effects include cardiac arrhythmias, osteoporosis, and muscle weakness. Older individuals and those with pre-existing cardiovascular disease are particularly vulnerable to these adverse effects. It is crucial to balance the benefits of therapy with potential risks and monitor patients closely for any signs of adverse effects. Rare but severe complications include iatrogenic thyrotoxicosis, particularly in older patients, and life-threatening thyrotoxic storm, especially in individuals with untreated or poorly controlled hyperthyroidism. In certain situations, combination therapy may be considered for thyroid hormone replacement. The addition of liothyronine, the synthetic form of T3, to levothyroxine therapy is a potential approach. However, limited evidence supports the routine use of combination therapy as the benefits are often outweighed by the increased risk of adverse effects. There are some situations, such as the presence of specific genetic polymorphisms or certain thyroid conditions, where a combination approach may be beneficial. Individualized treatment plans should be developed taking into account patient preferences, symptomatology, and careful monitoring of clinical response and thyroid hormone levels. Throughout the course of thyroid hormone replacement therapy, patients may need to transition between different formulations of levothyroxine. This can occur due to changes in availability, changes in brands or formulations, or patient preferences or considerations. When transitioning between formulations, close monitoring is essential, as different brands or formulations may have variations in bioavailability and pharmacokinetic properties. Assessment of thyroid hormone levels and clinical symptoms is crucial to ensure optimal therapy outcomes during the transition period. Healthcare providers should educate patients about the importance of consistency in taking the same brand or formulation of levothyroxine unless directed otherwise by a healthcare professional. Effective patient education and counseling are vital components of thyroid hormone replacement therapy. Patients should receive clear explanations about their condition, treatment goals, and the importance of medication adherence. They should also be informed about the expected course of treatment, potential adverse effects, and when to seek medical attention. Educating patients on the need for regular laboratory monitoring and follow-up visits can help optimize therapy outcomes and prevent complications. Shared decision-making is crucial in tailoring treatment plans to individual patient preferences, goals, and lifestyle factors. Patient satisfaction and engagement are closely tied to clear communication and an understanding of the importance of long-term therapy in managing hypothyroidism effectively. In conclusion, thyroid hormone replacement therapy plays a critical role in managing hypothyroidism and optimizing patient well-being. Throughout this comprehensive script, we explored various aspects of the therapy, including its introduction, thyroid anatomy and function, etiologies of hypothyroidism, diagnostic evaluation, levothyroxine pharmacokinetics, management of special populations, dose titration, monitoring strategies, adverse effects, combination therapy approaches, transitioning between formulations, and patient education and counseling. By gaining a thorough understanding of these topics, healthcare professionals can effectively tailor treatment plans to individual patient needs and optimize therapy outcomes. Stay informed, stay attentive, and continue to contribute to the advancement of endocrinology and the well-being of those under your care.